Hey everyone! Before we kick things off, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, welcome to today's explainer. I am absolutely thrilled to have you here because today we're unpacking the true central engine of hospital finance and compliance. I'm talking about the IPDRG system. You know, if you've ever wondered how a massive hospital translates the incredibly complex reality of everyday patient care into a single, structured payment, well, you are in exactly the right place. We're going to build this concept from the ground up, step by step, so you can see exactly how clinical reality becomes financial reality.
Okay, let's dive into this and look at our roadmap. We've got 6 parts today. 1. Decoding IPDRG medical coding. 2. The MSDRG architecture. 3. Identifying the principal diagnosis. 4. The power of CC and MCCs. 5. Present on admission rules. And finally, 6. Clinical documentation integrity.
So let's jump right into Section 1, Decoding IPDRG medical coding. To really get this, you have to realize that inpatient coding isn't just about tallying up a bill for individual services. It's not an a la carte menu. It is really about categorizing an entire clinical picture. IPDRG stands for Inpatient Prospective Payment System Diagnosis-Related Group. Now, the absolute key word here is prospective. Under this system, hospitals are reimbursed a fixed, predetermined amount based on the patient's assigned DRG, and that's determined before the patient even leaves the building. It covers the entire episode of care, regardless of the actual length of stay or, the number of aspirins they were given. Think about the journey of a patient's chart through the hospital. It's actually fascinating how everything connects. We start right at admission, move through the actual care delivery where all that crucial clinical documentation is generated, and then we arrive at the coding phase. Here, coders assign the ICD-10 codes, which are then fed directly into a DRG grouper software. And that single DRG output, that is what populates the UB04 claim form, ultimately driving the entire revenue cycle management workflow. Moving on to Section 2, the MSDRG architecture. Let's look under the hood at this logic engine. The MSDRG grouper is, at its core, a massive, complex logic engine. It definitely doesn't just guess. It requires very specific inputs to assign a patient into one of exactly 25 major diagnostic categories, or MDCs. To do this, it looks at the principal diagnosis, any secondary diagnoses, procedures, which, by the way, partitions the case into either a medical or surgical tier. And it factors in patient demographics like age, sex, and discharge status. A really cool feature of this architecture is the triplet structure for severity levels. Take heart failure, for example. It actually splits into 3 distinct tiers. You've got DRG 293, which is heart failure without complications, then DRG 292, which is with a complication or comorbidity, a CC, and finally, DRG 291, which is with a major complication, an MCC. So you see, it's the exact same base disease, but with completely different resource needs. So the crucial point of all this comes down to this really simple formula. The hospital's payment equals the base rate multiplied by the DRG's relative weight. Just to put that into perspective, let's say a hospital's base rate is $6,000. If an MCC pushes the relative weight of that heart failure case we just talked about up to 1.3, the hospital earns $7,800. It makes perfect sense, right? Higher severity rightfully dictates higher reimbursement to cover those extra resources. All right, Section 3, Identifying the Principal Diagnosis. Let's talk about the PDX. To get the patient into the right category, identifying the principal diagnosis is absolutely the most critical input. And there is a really vital contrast we need to make here. The primary reason for admission is just the chief complaint on day 1. But the principal diagnosis, that's the condition established after study to be chiefly responsible for the admission. For example, if a patient comes in clutching their chest, the primary reason is severe chest pain. But after EKGs and lab tests, they're officially diagnosed with an acute myocardial infarction. The MI is the principal diagnosis that drives the DRG, definitely not the chest pain. And you can see this concept play out in real clinical practice. If you look at a standard inpatient face sheet, you'll often see an admitting diagnosis, something vague, like a fever of undetermined origin. Now, that is administratively important, sure. But as financial teams know all too well, that admitting diagnosis does not determine the MSDRG reimbursement. The true principal diagnosis, the one established after all the tests are run, is the only one that matters. Let's hit Section 4, the power of CC and MCCs. These are your severity multipliers. Once we actually have our principal diagnosis locked in, secondary diagnoses act as severity multipliers. A CC, like a simple anemia or a UTI, adds moderate severity. But an MCC, a major complication like acute renal failure or sepsis, that indicates a massively high level of severity and resource use. Documenting these secondary diagnoses accurately is exactly what pushes a case up that triplet structure we looked at earlier into a higher payment tier. Let's spotlight the real financial stakes with this number: $2,300. If a coder misses a documented secondary diagnosis of COPD on a patient who is admitted for simple pneumonia, the DRG drops completely down to the without CC tier. Based on our source data, that single missed code cost the hospital exactly $2,300 in lost revenue for just that one stay. So yeah, accuracy pays. Moving to Section 5, Present on Admission or POA rules, let's see how this builds. Because Medicare isn't just handing out higher payments without some serious checks and balances. Every single diagnosis on a claim must have one of these POA indicators attached to it. A Y means the patient arrived with the condition. An N means they developed it after they were admitted. Basically, this tracks exactly what the hospital inherited versus what happened under their watch. So let's ask the critical question. What happens if a severe complication, like sepsis, develops after admission? Well, it gets a POI indicator of N. And under the Deficit Reduction Act, conditions flagged as N are often classified as hospital-acquired conditions, or HACs. The rule here is incredibly strict, and HACs simply cannot be used to increase the DRG weight. The hospital essentially has to absorb the entire cost of treating that sepsis. And that brings us to our final part, Section 6, Clinical Documentation Integrity, or CDI. Because precise words carry such massive financial weight, clinical documentation integrity acts as a vital bridge. Think about it. A medical coder can only code what the doctor actually writes. When doctors use vague terms like probable or just simply write anemia, CDI teams have to send queries to clarify. But there are strict rules for this. A leading query is biased. You literally cannot say to a doctor, "Can we code this as acute blood loss anemia?" That's putting words in their mouth. Instead, a compliant, non-leading query simply presents the clinical evidence and asks the physician to clarify the severity completely on their own terms. We've basically built the DRG from the principal diagnosis all the way to the CDI query. Accurate coding is a direct mathematical reflection of clinical care. So I want to leave you with this final provocative thought. Is vague documentation leaving your hospital's revenue on the table? A single missed word or missed POA indicator can change a chart by thousands of dollars and instantly trigger compliance audits. Thank you so much for joining me on this deep dive into IPDRG. Before you go, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in the next explainer.